Welcome to our educational video on acute inflammation. Acute inflammation is initial rapid response to infections and tissue damage that develops within minutes or hours and lasts for a few days. It is characterized by the exudation of fluid and plasma proteins and the emigration of leukocytes, primarily neutrophils. Features of acute inflammation is summarized as rapid onset and short duration, mild and self-limited tissue injury, prominent local and systemic signs, characterized by edema, and neutrophils are predominant. Acute inflammation can be divided into following two events: vascular and cellular events. The vascular events involves changes in blood flow and vessel permeability. These changes leads to cellular events facilitating the movement of plasma proteins and leukocytes to infection or injury sites, followed by removal of offending agents. When an injurious agent is encountered, phagocytes in all tissues try to eliminate it. Phagocytes and other sentinel cells recognize the foreign substance and react by releasing soluble molecules that mediate inflammation. Some of these mediators stimulate small blood vessels, resulting in vascular and cellular changes causing acute inflammation to the affected area. Vascular events of acute inflammation. The earliest features of inflammatory response result from changes in the vascular flow and caliber of small blood vessels in the injured tissue. The immediate vascular response to injury is transient vasoconstriction, which can be mild or severe. Transient vasoconstriction follows persistent progressive vasodilation. This process first involves the arterioles and then leads to the opening of new capillary beds in the area. This results in increased blood flow at the site of inflammation, causing heat and redness. Vasodilation is quickly followed by increased permeability of the microvasculature with the outpouring of protein-rich fluid into the extravascular tissues. The mechanisms of increased vascular permeability include endothelial cell contraction. It causes leakiness, increasing vascular permeability mediated by histamine and bradykinin, and is short-term, reversible response to injury. Endothelial cell retraction. Vascular leakage occurs when endothelial cells retract, opening spaces between them. This immediate transient response triggered by chemical mediators is rapid, short-lived, and primarily affects post-capillary venules. Direct endothelial injury results in endothelial cell necrosis and detachment. It occurs in burns or by microbes and microbial toxin, and neutrophils adhering to the endothelium during inflammation can also injure it, amplifying the reaction. Transcytosis. It is process increasing fluid and protein transport. This process may involve intracellular channels opening in response to factors like vascular endothelial growth factor, which promote vascular leakage. The last step in vascular events is slowing or stasis. Fluid loss and vessel dilation slow blood flow, causing red cell concentration and increased blood viscosity. This leads to blood stasis, vessel engorgement, and localized tissue redness. Stasis leads to leukocyte accumulation and endothelial activation, promoting adhesion molecule expression and leukocyte migration into interstitial tissue. Cellular events of acute inflammation. Normally, leukocytes flow rapidly in blood, but in inflammation, they must be stopped and brought to the site of damage outside the vessels. Leukocytes travel from blood vessels to tissues in multi-step process controlled by adhesion molecules and cytokines. This process involves margination of leukocytes, then rolling over endothelium and adhesion to the endothelium, transmigration through the vessel wall, and movement toward the offending agent. Now let's learn the process of cellular events of acute inflammation in detail. Leukocyte adhesion to endothelium. The axial blood flow refers to the movement of blood along the central axis or core of blood vessel, typically in straight, streamlined manner. Due to slowing or stasis during inflammation, there's changes in the normal axial flow of blood in the microcirculation, in which more white cells enter into periphery of the vessel, process called margination. This positioning allows white cells to detect and react to changes in endothelium. Activated endothelial cells express adhesion molecules, causing leukocytes to roll over the endothelial cells lining the vessel wall, and this results in rolling phase. and eventually adhere firmly by forming a transient bond between the leukocytes and endothelial cells. Leukocyte adhesion to endothelial cells is mediated by adhesion molecules whose expression is enhanced by cytokines. Selectins and integrins are two major families of molecules facilitate leukocyte adhesion and migration in response to tissue stimuli. Selectins are receptors expressed on leukocytes and endothelium mediate weak interactions between them. Endothelial selectins are upregulated or activated at sites of infection or injury by cytokines and other mediators which recognize and bind to leukocytes through sialic acid-containing oligosaccharides. Leukocytes roll along the endothelial surface due to weak selectin interactions, slowing them down for further adhesion molecule recognition. There are three members of this family: heat-selectin, P-selectin, and L-selectin. Leukocyte adhesion to endothelium is mediated by integrins, which are transmembrane glycoproteins that bind to ligands on endothelial cells. Integrins are normally expressed on leukocyte plasma membrane in low affinity form and inactive until activated by chemokines. Chemokines activate leukocytes, increasing integrin affinity and leading to binding to endothelial ligands. At the same time, cytokines like TNF and interleukin-1 activate endothelial cells to express ligands for integrins, promoting leukocyte adhesion. These are some examples of endothelial and leukocyte adhesion molecules. The next step is leukocyte migration through endothelium. After being arrested on the endothelial surface, leukocytes migrate through the vessel wall primarily by squeezing between cells at intercellular junctions. This extravasation of leukocytes, called transmigration. After exiting the circulation, leukocytes move in the tissues toward the site of injury by a process called chemotaxis, which is defined as locomotion along a chemical gradient. Chemoattractants are chemical substances that attract cells or organisms by guiding their movement toward the source of the chemical. Chemoattractants can be bacterial products, cytokines, complement system components, or products of arachidonic acid metabolism. Chemoattractant bind to G-protein coupled receptors on leukocytes, activating second messengers that induce actin polymerization and myosin filament localization. This results in leukocytes migrate towards inflammatory stimuli by extending filopodia, pulling the cell in the direction of the chemoattractant gradient. Phagocytosis. After leukocytes recruited to infection or injury sites, they must be activated to perform functions like phagocytosis and intracellular killing. Phagocytosis involves three sequential steps. The first step in phagocytosis is recognition and attachment. Mannose receptors, scavenger receptors, and opsinin receptors present in host defense cells that bind and ingest microbes. The macrophage mannose receptor lectin specifically targets microbial cell walls by binding to terminal mannose and fructose residues. Scavenger receptors bind to LDL and microbes, enhancing phagocytosis when microbes are opsonized. Opsonins, including IgG antibodies, complement activation products, and lectins are recognized by leukocyte receptors. The next step is engulfment. Phagocytosis involves opsonized particles being engulfed by phagocytes through pseudopod formation, leading to the formation of phagosomes that fuse with lysosomes to form phagolysosomes. The next step is killing and degradation. Phagocytes kill and degrade microorganisms using antibacterial substances and hydrolytic enzymes. The mechanisms include oxidative and non-oxidative bactericidal mechanism. In this mechanism, the phagocytic leukocytes produce reactive oxygen metabolites through NADPH oxidase, causing oxidative damage and microbicidal killing. NADPH oxidase present in the cell membrane of phagosome reduces oxygen to superoxide ion. Superoxide is subsequently converted into hydrogen peroxide, which has bactericidal properties. The bactericidal activity occurs via myeloperoxidase or independently of myeloperoxidase. Through MPO-dependent killing, the enzyme MPO in the presence of halides forms hypohalous acid from hydrogen peroxide, creating more potent antibacterial system than hydrogen peroxide alone. and an MPO-independent, killing some mature macrophages lack the enzyme MPO and they carry out bactericidal activity by producing OH ions and superoxide singlet oxygen from hydrogen peroxide in the presence of superoxide ion, which is called Haber-Weiss reaction, or in the presence of Fe+2, which is called Fenton reaction. The next mechanism is by lysosomal granules. The lysosomal granules of neutrophils in macrophages which release performed products into phagocytomes in the extracellular environment. This degranulation, along with oxygen-free radicals, induces proteolysis, and through the non-oxidative bactericidal mechanism, lysosomal granules cause phagosome lyses and nitric oxide produced by endothelial cells in activated macrophages, microbes, through reactive free radicals. If you found this video helpful, please like, share, and subscribe.